Dr. Linda Bluestein is the founder and sole proprietor of Hypermobility MD and the host of the Bendy Bodies podcast. We discuss how to distinguish hypermobility from a hypermobility disorder. We also discuss common non-joint related pathologies that those with hypermobility connective tissue disorder may have, from POTS syndrome to mast cell instability. At the end, we discuss some case presentations that are near and dear to my heart. Dr. Bluestein is a national, international, and invited speaker, is at the forefront of research on pain, hypermobility, and dance medicine. She's written and lectured extensively on the topics of pain neuroscience, chronic pain, and hypermobility disorders. Dr. Bluestein repeatedly receives top reviews from the medical students from her teaching abilities and is a member of the clinical faculty at the Medical College of Wisconsin, Central Wisconsin, where she also serves as the course director for the RISHI Healers Art Program. She is a product of the California education system, having gone to undergrad at UC Irvine and med school at UCLA, and then did her anesthesia residency at the Mayo Clinic.
Welcome to the Physician's Guide to Doctoring, a practical guide for practicing physicians. Dr. Bradley Block interviews experts in and out of medicine to find out everything we should have been learning while we were memorizing Krebs cycle. The ideas expressed on this podcast are those of the interviewer and interviewee and do not represent those of their respective employers. And now, here's Dr. Bradley Block.
Dr. Linda Bluestein, thanks so much for being on the podcast.
Thanks so much for having me.
So before we start talking about bendy bodies, let's talk about how an anesthesiologist ended up treating bendy bodies. So how did you get started? How did you make the transition? And how did you set up your practice?
So I actually am a dancer myself by this is how I started out. Like, I wanted to be a professional ballet dancer. That was my dream. And my body, though, had other ideas. I have a bendy body, in case probably a number of people already know that by now. So I went on to medical school because I needed a plan B, which worked out, quite well for me, and chose anesthesiology because I was always interested in pharmacology and physiology, and I'm not a very patient person. So the idea of things happening very rapidly really appealed to me. So I practiced anesthesiology in the operating room for over 20 years, and then had a series of different things happen to me medically that took me out of the operating room. And in the meantime, I became super interested in what kind of treatment options there were for bendy people. And so I started to do lots and lots and lots of research, basically created my own kind of mini fellowship. And I've always been super interested in integrative approaches to different medical conditions, so addressing sleep issues and nutrition and things of that nature. So I realized after I was able to improve my quality of life really, really significantly, that perhaps this approach would work with other people. And I had written a couple of articles that got a lot of attention, and I had people emailing me and saying, "Where can I come see you?" And initially I didn't have a place. So I ended up opening a clinic, and then I live in the middle of nowhere, and people, the whole, if you build it, they will come kind of a thing. I built it and they came. So that was pretty exciting. I opened my clinic back in 2017, and then ended up actually more recently switching the name of my clinic from Wisconsin Integrative Pain Specialist to Hypermobility MD to reflect the broader nature of what I'm doing, because I do have patients from a pretty diverse area. And the bendy part of this, that I really want to work a lot with the population that's really underserved, like the dancers and other flexibility type artists and athletes. So I thought that's a good name for, kind of attracting those kind of people that might not really want to go to a quote unquote pain clinic.
Okay, so now it makes more sense going from anesthesiology, right? Because one of the fellowships for anesthesia is pain. So
right.
You go from anesthesia to pain, and then from pain to specifically working with pain in this subpopulation.
Exactly.
Okay.
Yeah. And I had a pain practice when I first finished my residency, my anesthesia residency. I did do pain management for a few years, and then worked more strictly in the operating room for a while, and then back to doing pain. So, yeah.
Okay. What are the logistics of setting up a practice that's not necessarily within your specialty? Or is this all within your specialty?
So, because of the link with anesthesiology, I mean, I did do quite a few rotations through the pain clinic and things like that as an anesthesia resident. So that's just a part of your training. And yes, now there's much more fellowship training. And if you're going to do interventional pain management, then that's something that is definitely, very necessary, I believe, because of the fact that I was taking more of this integrative approach, and I do some procedures, but pretty minimal, mostly like trigger point injections and that kind of thing. Through my career, of course, in the operating room, I did many, many procedures. I did lots of, putting in lines and things and doing blocks for post-op pain or for the actual procedure. So say you're going to be doing sedation, but you're going to be doing an axillary block or an interscaling block or something like that. So it was a very natural fit and of course, pain management is a part of what you're doing in anesthesia. It's just that you're doing more acute pain management, whereas now I do more chronic pain management.
And it makes sense, right? It is. I saw your practice more of like a musculoskeletal, like physiatry, like I would see a physiatrist is doing. But really, if the focus is on pain, I think of fellowship as a relatively new phenomenon. In my field of ENT, there are plenty of ENTs that feel totally comfortable doing rhinoplasty without doing a fellowship. So, I understand the focus is really pain, which is an extension of and part of anesthesiology.
Right.
The focus is pain in this subpopulation, not mobility and musculoskeletal injuries per se, right? You're not doing physical therapy necessarily with these patients.
No, I refer them to physical therapy very, very frequently. And I, especially now with the, coronavirus happening, I love it when I get a referral from a physical therapist, because I often then will call them afterwards and discuss, what their findings are. And that's a really nice complement to what I'm doing. And then I give them information that will help them, move forward with the patient. So I really like working with physical therapists with this population, because I feel like our skill sets are a very nice fit for each other.
And I'm sure that makes for a great relationship. That was actually discussed on my episode a few episodes ago with Andrew Tisser, where he had interviewed a bunch of different of the allied health professionals, and they all, as at the beginning of his podcast, and then he pivoted to a different theme, but they all said the same thing. Guys, call us more, talk to us more,
right?
Like, reach out to us more, have conversations with us about these patients, and they're going to get better care. So it sounds like that's happening a lot on your end. That's fantastic. Okay, so when we're dealing with this population of people that have hypermobility, it's something that we definitely do learn about in medical school, right? I've heard of Ehlers-Danlos and Marfan syndrome, and I'm sure I've answered tons of multiple choice questions. But if you had a med student rotating with you, this is where we get to like what every doctor should know about bendy bodies, whether it's hypermobility associated with the disorder or just more mobility than you would think, most people have. So what would you want the big takeaways being for a med student if you didn't know what that med student was going into? Maybe they're going to something that's completely unrelated, that's never going to refer you patients, but they're still going to have people that they meet in their community that might have questions for them. What do they need to know about bendy bodies? So
the first thing is that hypermobility disorders, which is the umbrella term that a lot of us use to, that includes, yes, Marfan's, Ehlers-Danlos syndromes, osteogenesis imperfecta, other truly hereditary disorders of connective tissue, and then also the newer category, hypermobility spectrum disorders. But if we lump all of those together, we know that hypermobility disorders are absolutely not rare. They're rarely diagnosed, but they are not rare. So that's the first thing. And it's one of those diagnoses that I believe that people should always have on their radar, to just be keeping in mind, like, if things don't seem to add up, then could hypermobility, symptomatic hypermobility, be part of what's going on here? There's a lot of psychologic and physical sequelae that happen because a lot of people go many, many, many years without being diagnosed. So the first podcast I started was Hypermobility Happy Hour. And then the podcast I have now, Bendy Bodies, those have been actually widely popular. I get emails every single day from patients. I get them from physical therapists. I get them from physicians. I get messages all the time from people who either they say, gosh, I see these people in my practice and I don't really know what to do, or I have this problem and everyone, just blows me off and I'm not getting the kind of care that I need. Where can I go? Who can I see? So that's the first thing, is that hypermobility disorders, when we, have this category, all of them together, they're not rare. So this is an important thing to have on your radar. Is this person hypermobile? And I would add to that, are they hypermobile like Gumby, or are they hypermobile and loosey-goosey like Raggedy Ann? And those, for a lot of the younger people in the audience, hopefully they'll know what those characters are. But Gumby is the green thing that you can kind of bend into different shapes. And
Stretch Armstrong, although that's probably the same generation. Yeah.
Yeah, it could be. And Raggedy Ann is just floppy. I mean, I have patients that are 16 years old, and when you go to get them up to have them walk to do part of the physical exam, they just collapse. They don't have enough muscular development, muscular strength to support their joints, and their joints are so unstable that it requires more muscular strength. So it's really difficult for them to actually, make any kind of progress. So that's the first thing, is to just keep this on your radar. These conditions are not rare. The second thing is that these conditions occur on a spectrum. So all the way from someone who is the ballet dancer who is, super, super flexible and, maybe has had a few injuries or some issues with, something taking a little bit longer to heal, but otherwise is doing great, all the way to, people who are very, very significantly impacted and are basically bedridden, and everything in between. So it's important to keep in mind that, just because somebody doesn't look like how you think they're going to look doesn't mean that they don't have one of these conditions. I guess the next thing I would mention is it's important to know what the hallmarks are of these conditions. So the joint hypermobility being one. The other is weak tissue. So, get injured easily, take a longer time to heal. We end up with things like hernias or pelvic floor prolapse, things like that. And then the other thing is skin changes. So, again, scars that look abnormal and that kind of thing. And the last thing that I just want to mention is there are some very, very common myths that surround hypermobility disorders. Oftentimes people think that if someone is bendy, that they must have a hypermobility disorder. And if someone is bendy but doesn't have any symptoms whatsoever, then they have joint hypermobility, but they don't have a disorder. They don't have any symptoms. So that's the first myth. The second myth
before we get past that myth, let's make the distinction. Like, what are the questions that we would ask to distinguish hypermobility from a hypermobility disorder, right? What are the signs? Like you mentioned wound healing. So if they have some strange scars, I would imagine like some of the patients have fragility within the blood vessels. So maybe easy bruising. What are some of the other questions that we're going to ask?
Yep. Those are some of the other things that you want to know. Some of the findings are things that you find like on an echo. Some of the things have to do with arachnodactyly. So, having longer fingers and toes. And, some of the tests for that are, where you wrap the fingers around the wrist or you close the hands, and can the thumb, if you make a fist, does the thumb actually protrude past the fifth finger? That's another test that people do. And then also something called piezogenic papules. When people are standing, you actually have to I usually crawl on the floor to look at their heels for this. But they're basically like kind of globules of fat that stick out through the skin of the heel. But the person needs to be weight bearing. So they need to be standing. And then you really need to get down on the floor in order to be able to see that. So that's another thing that we see.
So if your mobility is an issue, it makes that part of the physical exam significantly more challenging.
It definitely does. Yes, definitely. And pain is a really, really huge problem with this population of people. So if they have higher pain sensitivity or have pain in more body parts, that's definitely a red flag to be thinking about this. And also if they have hyperalgesia or allodynia. Of course, not everyone who has hyperalgesia or allodynia, meaning hyperalgesia is when you are exposed to a stimulus and instead of having the expected level of pain, you have more pain. So that's hyperalgesia. You have a greater level of pain for the stimulus that was, you get, somebody scratches your arm and it's like excruciatingly painful instead of just like, it feels like a scratch. And then allodynia is when something that is normally not painful at all is painful. So the classic example is, sheets touching your foot. So people that have connective tissue disorders are at much greater risk of having sensitization of the nervous system and having hyperalgesia and allodynia.
So what is myth number 2?
So myth number 2 is that in order to have a hypermobility disorder, you must be bendy. And part of the challenge is that we lose our bendiness as we age, right? So part of the challenge is oftentimes we don't have symptoms when we're younger because we are able to heal our bodies more easily. As we get older and we don't heal as well, we start to have potentially, more pain, more problems, but we're not bendy anymore, or we're a lot less bendy than we used to be. So myth number 2 is that you have to be bendy in order to have a hypermobility disorder. You actually don't have to be bendy in order to have a hypermobility disorder. So I know that's actually probably kind of confusing.
It's a contradiction, yes.
Yeah,
but you have to have been bendy at some point?
Exactly, right.
Okay, you just don't have to be bendy right now.
Exactly. Okay. And there's a questionnaire, the 5-point questionnaire by Dr. Hakim and Graham from 2003 that asks questions like, when you were younger, did you amuse your friends by, doing different tricks with your body and things like that? And then it asks a couple of the points from the scoring system that the Beighton score. I don't know if people will have heard of that.
No, let's assume no.
Okay, let's assume no. So the Beighton score is the most commonly used test in clinical practice for determining if someone has generalized joint hypermobility. But the problem with this test is that, number one, it's biased towards the upper extremities because 6 of the 9 points come from the upper extremities. And another problem was it was developed for research purposes, not really for clinical use. And like I just said, by the time people get symptoms, oftentimes they don't have this ability to do these maneuvers. So, for example, for me, the first rheumatologist that I went to, although actually I had been to a rheumatologist back when I was a teenager because I started getting joint pain when I was a teenager. But going to a rheumatologist as an adult, he did this test on me. And I don't remember what I scored, but it probably wasn't very impressive because I already had lost a lot of my mobility. I had already had multiple joint surgeries at that time. So that can make matters a lot more confusing if people are relying on that heavily. So I really like that 5-point questionnaire because it takes some of the things from the Beighton score from a historical perspective. Can you now or could you ever touch your thumb to your forearm? And that's something that in the Beighton score, you just have to be able to do it now. There's no historical component.
No.
You could never do that.
I could never. No, I could never. These questions do not apply to me. I am hypomobile.
Yeah, and that's some people are hypomobile and some people are hypermobile, and you can have hyper and hypo. You can have some joints that are hypo and some that are hyper. So,
nope, all of them hypo. Okay, so those are 2 myths. Are there any more myths that you?
There's one more
myth. Okay.
Yep. There's one more myth. So you actually can have a syndrome of joint hypermobility. So joint hypermobility is a feature of, think it's several hundred different genetic disorders. And you can have one of those genetic disorders and not have any symptoms. So that's, just another important thing to be aware of when you are, evaluating someone.
You mean like if there's a genetic test and it comes back positive because there's varied penetrance, they might not manifest any type of a symptom.
Yeah, either that or they haven't developed any symptoms yet. And, maybe later on they would. And I'm glad you brought up about testing because we can test for all the different types of Ehlers-Danlos syndromes except the most common type, the hypermobile type. We can test for the vascular type, the classical type, all of the other types, but we don't have the molecular marker for all of the hypermobile population right now, the hypermobile Ehlers-Danlos population.
Wow, interesting.
Yeah.
You would think that would be the first one that they'd find because they have the largest population pool, but I guess it doesn't, or may not even have. It might be varied in its genetics as well, even though the presentation is similar.
Right. I think that's exactly what it is. So what we're thinking now is that these people that appear to have hypermobile EDS, they're phenotypically similar. They look the same. They look like they have, or the same-ish. I had a patient tell me once it's an owner-specific diagnosis. And I thought that was such a great way to put it because no two people are, we know that anyway in medicine, right? That no two people are identical, but it's really, really true of this population. And there's also a saying, if you've seen one person with EDS, you've seen one person with EDS. They're very, very, there's a lot of variance, I guess I should say. Yeah. But once you start to recognize the pattern, then you definitely are able to recognize it more easily. And the thinking is that we are going to discover that there's several different genes involved, but that also there's other reasons why these groups of people are looking like they have the same condition when probably they are actually similar manifestations, but of different genetic problems.
Yeah. Let's get a little more granular, right? So that was, I think, what everyone should have knowledge of if they're a physician, because, one of my neighbors might be stretching before we play basketball and I notice something and then, a scar, maybe put two and two together and they might ask me a question. I might be able to point them in a direction they might not have even known to go. But let's get more granular with what you think physicians that are going to see this more often should know, that probably have a significant background in it, but there might be some subtle aspects that you tend to have are at the forefront of your attention because you see it more. So like orthopedic surgeons, neurologists, physiatrists, rheumatologists, I would guess that these are the specialists, cardiologists, that are seeing these patients, but more specifically to the hypermobility issues, like the ones that you're going to see. I guess a cardiologist isn't necessarily nobody's going to be complaining to them that their shoulder hurts and, show them how they take it out of their socket.
But, it's a very interesting question. And it's very interesting actually that you chose cardiology as one of the specialties because there is a lot of overlap between hypermobility disorders and a couple of other conditions, one of which is dysautonomia. So dysautonomia being dysfunction of the autonomic nervous system. Yes. And the most common condition that we see with people that have hypermobility disorders is postural orthostatic tachycardia syndrome, or POTS.
Yep. I am familiar with that because we see lots of dizziness in otolaryngology.
Yes.
Right? So they come to us. And because it's positional, right? Benign paroxysmal positional vertigo. Classically, when you lie down and turn onto one side, you experience vertigo. And these patients experience it positionally, but not that position.
Right.
They get it when they're standing up because then they're not getting as much blood flow to the brain. So they come in with this positional dizziness that some of them experience with vertigo, and they're put on meclizine and sent to see the otolaryngologist.
Right. Yeah, absolutely. And even within cardiology, there's a lot of cardiologists that will see these patients and work them up and do a tilt table test and, start them on the appropriate regimen, which usually start conservatively with, more fluids and sodium in the diet. And it depends on their age too. So a lot of times if they are going through this process, it can happen more like in the teen years, if they're having a growth spurt or something like that. But then over a period of time, there's a large percentage of people that where these symptoms will lessen quite significantly. So it's not uncommon for people in the teenage years to complain of, if I stand up too quickly, then I get dizzy, and then I get the curtains kind of coming in, that kind of thing. But these people, that doesn't go away. It continues and persists. And actually part of the diagnosis for POTS is related to the heart rate change with going from sitting to standing, or with the tilt table test. And when these symptoms have to be present though for at least 6 months, because the other thing is if we take anyone and we put them in bed you go to get them out of bed and they're going to have this problem. So say someone has the flu or, gets coronavirus and they get, bedridden, or they're really sick for a little while, then they will definitely have this problem. So especially if they've had a febrile illness, because then it's really hard to keep up on your fluids.
Or if you're doing a Dix-Hallpike maneuver to someone where not only they're lying down, but their head is hyperextended. And then you sit them up. They will experience dizziness because everybody does. So that is not a diagnosis. Again, sorry, this is just because this is all about me. Benign, not benign paroxysmal positional vertigo. Okay, POTS syndrome. Actually, this is definitely important for me to know. So would you happen to know what the management is aside from increased sodium intake and fluids? What could people do for that?
So there are a number of other things that people can do for that. So there's a lot of things that you can do in terms of building muscular strength, especially in the lower extremities. That can really help. And especially like before people get out of bed in the morning, if you move especially your legs and do kind of some pumping of the your quads and squeezing of your glutes and things like that before you get up, that can help to at least improve, kind of some venous return back up to the heart. And at least, we know that veins don't have valves in them. So whatever we can do to help improve blood flow, because that's the other thing that I think is part of the problem is when people have a connective tissue disorder or hypermobility spectrum disorder, and it's very common to get deconditioned. We often will get injured doing very, very simple things. So we often get kinesiophobia, which is fear of movement. And so you kind of fall down the EDS hole or the EDS spiral. And we want to start to recondition the body, build up some muscle. Sometimes compression stockings can help improve that venous return. We do want to make a distinction if it's hyperadrenergic or not, because the treatment of that would be different. Clonidine is a drug that's often used for that. So sometimes we'll actually I don't do this, but a cardiologist will do this or neurologist. POTS is one of those disorders that can be treated by either of those populations, but those are the ones that are most frequently handling these patients on a, more intense management basis. So some of the drugs that are used include like I said, clonidine. Beta blockers are quite commonly prescribed. And I'm trying to think what else.
I would think you wouldn't want to block your betas. I would think that would be...
Right. Very low dose beta blockers. Yeah. Very low. You wouldn't think you'd want to block your betas. Yeah.
I remember hearing an attending say that, and I thought it sounded so cool.
Yeah, no, that is good. And midodrine is another very common drug that's used, and Florinef.
Okay.
So, yeah.
Okay, so POTS syndrome, definitely something to look out for in this population. What about if someone has POTS syndrome, consider working them up for a hypermobility disorder?
Yes, yes.
So what about other things that you would want these specialists who might be seeing these patients to know about those patients?
So the other disorder that occurs quite commonly with these patients is called mast cell activation syndrome. And we know that a lot of us think of allergies as being, more related to histamine and being a pretty, clear-cut type of problem. And we might have learned about mastocytosis. I know I definitely learned about mastocytosis in medical school, learned that it was very rare. And this is not mastocytosis. It's not an abnormal number of mast cells. It's an abnormal activation of mast cells. And so we know that mast cells have, hundreds of different mediators inside of them. And so it's not just histamine, it's histamine and tryptase and heparin. And each one of these mediators can have effects all through the body. So I had a visit with a patient yesterday, and one of the things that she told me, that I've been treating her for a while now, but she said that she has been told by other doctors when she was describing her symptoms, quote, "That's not possible," close quote. And that's so devastating to a patient.
Yeah, that's always discouraging.
Yeah. And the best thing you can do for these patients is to believe them, because these mast cell activation syndromes are very, very challenging. I mean, these people, they really suffer. They suffer these kind of bizarre symptoms that, again, I think had I not started this practice and see, the population that I do, I can see where a lot of people would think, okay, this just does not make sense to me. It's not anything that I learned about in medicine, and it doesn't make sense to me scientifically. So therefore, it must not exist. And because mast cells have so many different mediators, you can get some really unusual symptoms. And I've had some amazing results with people who I had this one patient who mom actually came to one of my talks, and mom came up to me afterwards and said, "Do you think you can help my daughter?" And she's describing this seizure type activity. And I said, I don't know, but I'd be happy to try. And so, they brought her in to see me, and I was looking over the records, and she was diagnosed with psychogenic non-epileptiform seizure disorder. And she would have these just, kind of random episodes of abnormal, muscle activity, and then she'd be just exhausted afterwards. And I thought, I wonder what would happen if I treat this like a mast cell activation disorder syndrome. And so I put her on antihistamines. I put her on some mast cell stabilizing drugs that we frequently use. And some of those are actually just supplements. But she came back.
Not Montelukast?
Well, that would be a possibility, but I did not prescribe that for her initially.
That's just immediately where my brain goes in terms of mast cells.
Yeah, that's definitely a drug that we do use. And she came back a month later and, asked her, "How are you doing?" And she said, "I haven't had a single episode since I saw you." And I don't know, my mouth is probably gaping open like, really? It actually worked? You don't really know until you start treating people and trying these things.
I'd probably start to cry.
Yeah.
That's how my office visit would go.
Yeah.
Because, you realize what an impact that has made on their entire existence.
Yes. I mean, she was really, really devastated with all of this. I mean, she had just learned how to drive. She wanted to go to college. And, here she had to stop driving.
Yeah, she saw her life taken away from her.
Yes. Yeah. And they had done this hugely expensive workup, including, MR angiogram of the brain. And they had her in the hospital for like 3 days under, a video EEG program. And so, and then to get this diagnosis, I've had other patients come to me with a diagnosis of conversion disorder. And, I've had patients that come in a wheelchair that are now walking. So it's, I guess the big thing is give them the benefit of the doubt. And it may not make sense to you, but if they're saying that they feel it, like, believe them. Obviously, we know patients do sometimes lie. We know that does happen, but that's by far the exception, not the rule. And until they've proven themselves to be untrustworthy, I think they should be believed.
Absolutely.
Yeah.
I guess in this situation, when you heard hoofbeats, look for the zebra, because it sounds like there is no necessarily horse for what this presented, for these symptoms. And I'm not totally clear on what the symptoms are. Actually, what is it that we're looking for this diagnosis?
Right. So if you're talking about, the Ehlers-Danlos syndromes and hypermobility spectrum disorders, I should say hypermobile Ehlers-Danlos syndrome and hypermobility spectrum disorders. So I should just clarify, in 2017, the International Consortium on Ehlers-Danlos syndromes and related disorders, they reclassified hypermobile Ehlers-Danlos syndrome, actually, and the other Ehlers-Danlos syndromes, because they wanted to be able to find the genetic marker for hypermobile EDS. And in order to do that, they made the criteria much more strict. And they knew that when they did that, they would be excluding a lot of people that, still fall into the category of having some kind of hypermobility syndrome. So they created this hypermobility spectrum disorder category for people who, have symptomatic hypermobility, but they don't meet the really strict criteria that now exist for hypermobile EDS. So anyway, so those two are very closely related, hypermobile EDS and hypermobility spectrum disorder. And amongst those, I'd say the most common symptoms are pain. GI symptoms are quite common. That's very, very common. They, again, sometimes have issues with healing. We know about the dysautonomia, the mast cell activation stuff. They'll have a higher incidence of like allergies and asthma, of course, population that you see.
Wait, so sorry, the mast cell degranulation, because I'm a little confused about how this patient was told that she had seizures and it ultimately was mast cell degranulation.
She responded anyway to treating the mast cell.
Well, no, but what were her symptoms or the typical symptoms of that? I mean, you're saying allergies and asthma, but how would it present in ways that we wouldn't know that it's like where the patients wouldn't end up on those medications anyway. Even if we thought, well, this is asthma or this is allergies, right? Because the symptoms are overlapping and therefore treating them as asthma or allergies with those medications, which are going to help. How is it that they ended up with conversion disorder and seizure disorder as these diagnoses? Like, what are the presentations that might be less?
So the other thing that because people have weak connective tissue, they're going to present with things like dislocations and subluxations. I'm sure everyone knows what a dislocation is, but a subluxation meaning that the joint is not in proper alignment, but the bones have not completely lost contact with each other. So, for example, this patient that I saw, she already had a diagnosis of EDS and she already had a diagnosis of POTS. They just, nobody had thought to treat this abnormal muscular activity that she had. She would get kind of like a prodromal, just feeling like something wasn't quite right, kind of feeling a little, very, very common for these people to have brain fog. That's a super common complaint amongst people that have POTS. And so she would get kind of a severe worsening of that before she would have this like muscle twitching type activity that lasted for anywhere between 30 and 90 seconds. And she would get sometimes 10 episodes a day, and other times go several days without having this. And then she would just be extremely fatigued after this happened. And a lot of these people too would be the person that you see, like for me as an anesthesiologist, people would come in and they would have a list of like 20 different drugs that they were quote unquote allergic to. And on that list might be like something like epinephrine. Yeah. I now know that that's because a lot of people with mast cell activation syndrome, they have sensitivity to the inactive ingredients in drugs or the excipients. So they will have these, what sound like kind of bizarre reactions to a lot of different medications, but it's because their mast cells are so like trigger happy. So it just takes very little for them to react that way.
Interesting. I think now we'll move on to the case presentation portion, unless there's anything else that you want to mention that you think that our other our allied specialists should be aware of.
There's one other thing that I want to mention, and that's regarding opioids. Just because since I practice pain management, of course, that's always a concern, and of course, it's really an issue right now in our society. And in this population of patients, long-term opioids is really rarely appropriate, but there are certain limited circumstances in which it is. So if somebody has very, very severely impacted, people can have instability of their cervical spine, for example, and end up having, surgery for that, and maybe they have a Chiari malformation, basically herniation of their brainstem into the foramen magnum. And, that can be of varying degrees, of course, but people can end up with some very, very severe complications from this. And then that's kind of a last ditch drug for me as far as my practice goes. I try a lot of other things before that, but I think it's important to avoid black and white thinking that like those are always bad or always good. In this population, they're rarely appropriate, but sometimes it is appropriate to either prescribe a small amount to be used if they have a dislocation or a subluxation so that they have it available. But because opioids cause mast cell activation, they're usually not the right drug for this population.
Good to know. So we're not using opioids for anybody anymore.
No, but we also,
we stopped using them for actually pediatric tonsillectomy a while ago, and switched it for ibuprofen, and actually everybody's been doing much better.
And they're doing okay with that?
Yeah. I've actually stopped using it except on rare occasions, septoplasties and sinus surgery. I used to give no NSAIDs. They'd only use opioids if they needed, but now I'm going back to ibuprofen and everybody's doing fine. So yeah, it's, we're moving in the other direction. I was in med school for the whole, fifth sign. Every doctor is insensitive to their patient's needs. You're all callous. You're all terrible people. And you all should be taking their pain much more seriously than you are and prescribing lots of opioids.
Right.
That was in the curriculum at the time. And now, the needle's swinging in the other direction. So it sounds like for this as well.
And I think in some instances, it's almost swung too far in the other direction. I guess I see people sometimes that have surgeries and don't get prescribed anything, and they have a lot of pain afterwards. So I guess it depends on the circumstances. It's fantastic if you have ways that you manage patients that they don't need them, that's the best thing. I mean, that's the best of all worlds. But I do think that sometimes we are almost so afraid of prescribing opioids that we're withholding them when it would be appropriate to prescribe them. I mean, like people having total joint replacements, at least these are some of the stories. These are some of the things that I hear from my patients. So,
for my adult tonsillectomies, acupuncture is not working. They need opioids. It is
exactly
brutal.
Right.
Okay, so now to the case presentation portion of the interview. and to keep his anonymity, I will just tell you that this is one of my sons. Since I have 3, I will not tell you which one.
Okay.
So he is ridiculously flexible. Like, since birth. When he takes his shirt off, he pulls it up over his head and then puts his arms straight back, like parallel to the ground and parallel to each other in order to get it over his arms. Like he just goes straight back and then down to like push the shirt off his arms. And, all of his mobile, we can, sometimes some clicking in his knees. We've brought it up to the pediatrician. They don't seem concerned. He doesn't have any pain. His strength is actually quite ridiculous. He's been able to do a pull-up since he's 2 years old. We just, have that stuff around in the house. I have gymnastic rings and pull-up bars. And so he loves playing on all that stuff. I don't know where he gets his athleticism from, certainly not from me. So I'm not worried about his strength, but how do I know that it is or it isn't, if it's just hypermobility or a sign of a hypermobility disorder? No issues with scarring. Actually, he did have an epigastric hernia, but so did one of his brothers. It's an unusual hernia that I'd actually never heard of, but it's a little midline defect. So really, no other scarring, no issues with bruising. He is, a typical boy throwing himself off of things he shouldn't be and whatnot. So what do I look for? How do I know if it's just hypermobility? And then also, how do I help him to harness it and at the same time protect against future injuries and future arthritis?
Right. So is his skin, would you say his skin is more elastic than what it's harder when they're young, their skin is, fairly, but would you say his skin is particularly stretchy?
No, actually that's one of his brothers who is not so flexible, has more of the stretchy skin.
Interesting. Okay.
Yeah.
Okay.
But no, not stretchy.
Sure. I think it's super important to think about, how we avoid injuries. So prioritizing strength and control is really important and all throughout the range of motion. So, if you think about, watching people at the gym who might be doing something using momentum rather than control to lift weights, that's not what we want to do. We want to do more, slow movements with strength training so that throughout the entire range of motion, they're developing that control. And your son, I believe, is young. So
yeah.
I know that this isn't necessarily, I'm giving kind
all
of a
3 of them
general,
are under 5. So.
Okay. You got a full house.
We do. It's rough.
Yeah. These are more kind of also applying to a broader range of people as well. It's hard when they're that young to advise them on that kind of a thing.
It's interesting that you say that because with CrossFit, right? One of the things that they do there is a muscle up, where you basically go from a pull up and then you push yourself up on the bar. Like you get yourself over the bar and then you push yourself up. And what they have people do is they have people swing into it. They call it kipping, but you're basically swinging into it. So you're swinging yourself such that you're above the bar. And I would think that if you're going to do that, I think that could be fine as long as you have the control to also do it without swinging.
Right.
So by using momentum, you're putting yourself at higher risk for injury, where it's not necessarily a bad thing, but make sure you can do it without the momentum first.
Right. Because if you're training, it's good to do some plyometric type activities. That's a good idea. But for protecting your joints, you don't want to be doing, herky-jerky type movements. You want to really make sure that you are, having the joint in proper alignment and that kind of things. As you're describing how he's taking off his shirt, I'm thinking about how I realized, oh gosh, I had to be in my 40s when I realized that my entire life, I basically had been like dislocating my shoulders to take off like really, really tight clothing. You just don't think anything of it. You just do it, and part of the challenge with hypermobility disorders is, we each only know what our own body feels like.
Yeah.
So
that's the easiest way to do it. So you're going to take the path of least resistance.
Right. lots and lots of dancers, particularly, they'll do these things where they're either overstretching or they'll be going into the hypermobile, range, in part because it's aesthetically it's advantageous, but we want to avoid that as much as possible. So if I can catch somebody as young, like as your son is, I definitely, without trying to make them, overly worried about it or anything, you want to try to avoid going into that hypermobile range. So maybe teaching him a different way to take his shirt off, or keeping an eye on that and seeing, well, when does it
pull
seem
your
like
arms out first, like most people do, and then push it
Right.
over your head?
Right. Exactly.
Yeah.
Exactly. Kind of looking to see, when is he doing things that look like he might be putting extra strain on the joints that really, on the ligaments, this is potentially going to catch up with him when he gets older. And part of what I love about having the Bendy Bodies podcast is I get to talk to an incredible array of people, and we're going to be publishing this episode very soon, but we spoke with a principal dancer of a pretty big company, and she was sharing with us, with me and my co-host Jennifer Milner, about how she really had to learn how to control her hypermobility. And in the beginning, she was just kind of using it and kind of leaning into it and relying on it. She had to learn that instead of doing that, she had to really control it and learn to be more in tune with the position of her joints and things, because that's the other thing that's kind of a little counterintuitive, because at the same time that people can have a sensitized nervous system and have more pain, they also can have poor proprioception. So people that are hypermobile often don't even know that they're, bending their arm, past, straight.
Right, because they're taking it like, when I straighten my arm, I straighten it as far as I can, and I'm totally comfortable. They're straightening it as far as they can, and it's totally comfortable, not realizing they're hyperextending.
Right, not realizing they're hyperextending it and putting strain on ligaments and tendons that are really not meant to go in that direction. And unfortunately, by the time people have pain, oftentimes it's, it would have been much better to deal with it before that,
Yeah, and what is it? An ounce of prevention is worth a pound of cure.
Yes, absolutely. Yeah. So things like Pilates are very, very beneficial. Things like exercising in a pool is fantastic, because when you exercise in water, you have the contact of the water with the skin, helps with proprioception. And you can also exercise your muscles in a way that works the muscles, but it's easier on the joints. I often recommend that people exercise in a pool. And some of the other recommendations that I give to dancers who maybe are not really having any particular problem yet, but they are at risk, that to be aware of things like overuse injuries. So I have one dancer patient who was, her studio was kind of showcasing her in this certain role that she had, and she did the same variation again and again and again in a whole bunch of different performances, rather than it used to be like back when I was dancing, and I was never as good as she was. She was a pre-professional dancer. She now had to retire because of her Ehlers-Danlos. She does have hypermobile Ehlers-Danlos syndrome. But back when I was dancing, we took tons of classes, and then we would perform every so often. And now I feel like there's a lot more performing going on. So they're practicing the same thing again and again and again, and there's less of the technique classes where, you're doing some of the maybe more boring things, or, working on really perfecting your technique that is going to be protective for you.
Well,
so
you're not going to be able to throw that up on Instagram.
Right.
Come on.
Yeah, exactly.
I think that's where we are, right? So that makes sense. Back to basics to make sure you're protecting your joints. Yeah.
Right. And it's also really challenging if you're a studio owner, your client is the dancer and their parents. And I've talked to lots of studio owners. I've talked to lots of dance parents. And sometimes if the studio owner says, no, you know what, I'm going to take away their point shoes, or I'm going to let them keep their point shoes, but I'm not going to actually let them go up on point because that other studio put them up on point too soon. Well, sometimes the parents will pull their kid out of that studio. So the studio owner is kind of stuck. Yeah. It's challenging.
Well, that's what I think happened with CrossFit, was like, I know you've never been able to do a pull-up before, but we're going to teach you to do a pull-up, because we're going to show you how to swing into it. And now you have a bunch of people that have never been able to do a pull-up in their whole life, and yet now they can because they're swinging into it. But that's putting them at high risk for injury. So it's a marketing strategy for them that helps to build their brand and their business. It's, it's a calculated decision. There might be the benefit, though, to this as someone who wouldn't have stuck with exercise. Now they are, because they have this positive reinforcement of now they can do this thing that they've never been able to do before. So I can see both sides, but
yeah,
safety, we're going to be more concerned about safety than, you might be able to rationalize though the other side. Like, well, I'm going to let them do this, but because I will keep a closer eye on them than other else might, then it's okay. So that's how we get to sleep at night.
Yeah, no, I think that's a great point about CrossFit. And even when you brought it up earlier, I didn't even think about, right, that they're getting the buy-in from people maybe that way, which is great that they are exercising. But I think the other thing that I think is so incredibly important, because yes, I want people to exercise as much as they possibly can. But the other thing that I think that we as a society need to remember is listen to your body. I cannot believe how often people will say, well, it hurts when I do X, Y, Z. And the whole joke about, well, then stop doing whatever.
Yeah. Oh, I went to the doctor and it hurts when I do this. He said, don't do this. Yeah.
Yeah. So I think that we need to be, before we get this terrible injury or end up with having, something where we can't go back. We are not able to get the tissues to heal. It's appropriate to listen to our bodies, and especially since in something like dance, overuse injuries are much more common than acute, traumatic type injuries. So it's just important to be aware of these things. And, is this getting worse? Is it getting better? What can I possibly modify because the other thing that's important is active rest. You don't have to quit completely. Perhaps you can just modify things somewhat to allow those tissues to heal.
Give it more time than you're probably giving it. And I think that's where a lot of the benefit of the physical therapy comes in too, is just, it's reinforcing, no, don't go back to what you were doing before. Give it more time. Let's get back to basics and build it up from the ground up.
Right. Because there's a big difference between, DOMS, delayed onset muscle soreness, that can really hurt a lot, but that's a good sensation usually, and that generally means that you're making your muscles stronger. So that's a good thing, versus pain in a joint or pain in a where a tendon inserts or something that Achilles tendinopathy, for example. You want to pay attention to that.
Yes, especially if you've been on a quinolone recently.
Right. Oh, that actually is another thing that I'm so glad you brought that up. In general, we avoid fluoroquinolones in this population because their connective tissue is weak already. So the last thing they need is something that's potentially going to make it weaker.
But if they've got a raging otitis externa and it's not responding to drops, it's either that or IV Zosyn, so we might not have a choice.
Yeah, exactly. It's weighing, that's what we do in medicine,
or put a PICC line. Yeah. All right, so second case presentation. And I have permission. This is my wife, right? She's very tall. She's 3 inches taller than me. Sitting down, I'm taller than her. When we stand up, she's taller than me. She is much taller than her siblings. She's much taller than her mom. And all of that is in her very long, lovely legs. She also has long fingers and long toes, and she's flexible. So I'm sure that's where my son gets it from. But she also has a tendency to scar easily. So I remember she's got this one scar on the back of her arm from reaching over a chain link fence and getting scratched. It didn't seem like that much at a time, but now it's not a keloid, and it's barely even a hypertrophic scar, but it's definitely visible. I mean, maybe because she has darker skin. I'm not sure, but those are the things that made me, when she was pregnant with our first son, say to her OBGYN, does she need to get an echo? I'm worried she might have Marfan syndrome or something. I still don't, this isn't my specialty. I'm sure I answered a question on a board exam at some point, but is anything that I'm telling you sound like it could potentially be hypermobility connective tissue disorder?
Definitely. I mean, it's interesting that you mentioned about, her body habitus, because there is that, ectomorphic body habitus does tend to be more common, but it's not always the case. But, in terms of criteria for Marfan's, based on what you've described to me, if that was my patient, I mean, I probably would get a baseline echo just to make sure that the aortic root looks okay. And I don't know what her wingspan is, but that's the other thing is, checking the wingspan versus the height. And, there's new mutations. So just because somebody does not have a family history definitely does not mean that, that they can't have a hypermobility disorder or a hereditary disorder of connective tissue. I actually know of a family where very, very tragically, a young lady died at age 15 of vascular Ehlers-Danlos syndrome. And there are multiple other family members that appear to have like hypermobile Ehlers-Danlos. So they've been tested for vascular, is my understanding. They're not my patients. I've met them elsewhere, but they at a fundraiser, and a lot of them were sharing their story with me. So the whole thing is really quite complex because, it's that person, the one who passed away, had a vascular fragility, gene, and also had the hypermobility, but the other people in the family have the hypermobility, but not the vascular fragility. So.
Oh, so that must have been a new mutation.
Yeah.
Yeah.
Exactly.
Well, is there anything else that you think bears discussing or bears repeating that you think either every physician or referring physicians should know about hypermobility disorders?
I think probably the most important thing is that, in our society, we kind of, I think, tend to idolize people who don't feel pain and, oh, wow, look how brave they are or whatever. And the more patients that I see that have these connective tissue disorders, and as they experience different things, a lot of them, they really suffer so much. And it's just amazing to me how brave and strong they actually are. So rather than idolizing people who don't feel pain, I feel like these people who truly have all of these sensations going on in their body, yet persevere anyway, and continue to get up out of bed in the morning and, try to do their best and really try to function as well as they possibly can. I think it's really amazing. It's so inspirational to take care of these people because they are truly, truly remarkable. They really are.
Yeah, it's like overcoming fear is bravery. Absence of fear is stupidity.
Right.
So it's the same thing with pain. They're able to overcome it is something to be appreciated.
Yeah.
And revered.
Yeah, exactly.
So where can people find you online? Where can people find your podcast? And where can people find your practice?
So the hypermobilitymd.com website is where, pretty much everything is housed. So from there's a medical services page that people can access. And I'm located in Wisconsin, so I can see patients that reside in the state of Wisconsin. Right now, because of coronavirus, there's a little bit of changes to the rules. It used to be that you had to fly to Wisconsin to see me in order, because the first visit had to be in person, but now it's a little bit different. And I do actually, at the present time, I do have an emergency Georgia license, so I can also treat patients that are in Georgia.
How did that happen?
I have
Wisconsin and Georgia.
I know. I have a couple of very, very dear friends that are physical therapists for the Atlanta Ballet. I was talking to them and they said, we really need you in Atlanta. And my son actually just graduated from Georgia Tech with his master's degree. And so I've spent a little bit of time in Atlanta. And yeah, I know Georgia seems like kind of why would you? And I have family there too.
We're expanding from Wisconsin to Georgia.
From Wisconsin to Georgia, yeah. So I looked it up and I found that, yes, you could get an emergency license. A lot of the states, I don't know who else is going to listen to this podcast, but if you have any ability to influence this, anyone who's listening, please make it easier for those of us who want to help people from different states to figure out if we can or can't, right now with COVID, because it's really quite confusing. Some states make it pretty clear what you can and can't do, and others, there's so much legal jargon in there that it's really quite challenging. But Georgia was great. It was clear where the application was, and then they've extended the date of the emergency and stuff like that. So they've been really good to deal with.
You hear that, Mom, and the other person listening to the show? All right. Well, I really appreciate your time and your expertise. So this has been great. And for the consults, not medical advice, appreciated, but no, not legally binding. We're not in a doctor-patient relationship, but but this was fantastic. I really learned a lot that I can apply to my practice, especially with the POTS syndrome, and to my everyday life. So it's really been a pleasure. Thank you very much.
Oh, you're very welcome. It's been great to chat with you, and I really enjoy your podcast a lot. So I'm super excited that you had me on as a guest. So I appreciate it. Thank you.
That was Dr. Bradley Block at the Physician's Guide to Doctoring. He can be found at physiciansguidetodoctoring.com or wherever you get your podcasts. If you have a question for a previous guest or have an idea for a future episode, send a comment on the webpage. Also, please be sure to leave a 5-star review on your preferred podcast platform. We'll see you next time on the Physician's Guide to Doctoring.